me 1 second. So there's going to be a few questions throughout as well. So I know that the chat is disabled, but you can write any answers in the Q&A tab. And if you have any questions as well, just feel free to either put your hand up or just put it in the question and answer tab as well. And I can answer them either at the end or as we go along. So we're going to be talking about bronchiolitis. Just a brief thing about bite medicine. So they're obviously a medical education page and they have an online textbook as well as loads of questions. And I think they have up to 600 topics now, as well as you can edit the notes and make your own notes alongside too. So going on to our aims and objectives. So we're going to understand the risk factors and features of bronchiolitis, focus on the referral/admission criteria, and understand the investigations and management. So we're going to go straight in with a question. So if a 7-month-old comes to ED with his dad, has a runny nose for the last few days, dad starts noticing that he's been sucking in his ribs whilst breathing. He's refusing his bottle and had around 1/3 of his normal fluid intake, and the observations are below. So if you guys can answer, what do you think the most likely causative organism is? And as I said, just drop it in the Q&A tab and I'll wait like 10 or 20 seconds and we'll move on to the answers. Cool. Yeah, it's RSV. So a bit of background around bronchiolitis. So it is an acute infection of the lower respiratory tract, and it's the most common LRTI in children below a year. So if you were to go into like peds ED or any peds wards, you probably see a lot of bronchiolitis. So around 90% of the cases tends to be between the 1st and the 9th month of life. So, or between 1 to 9 months. So because the reason why is because in neonates, it tends to be that the maternal IgG protects babies from RSV. So we tend to see it from 1 month onwards. That's not to say that they can't get it below 1 month, but demographic wise, it tends to be between 1 and 9 months. So the main cause is RSV, so the respiratory syncytial virus, and that's responsible for around 75 to 80% of all cases. But there have been known to be other causes too, like mycoplasma and adenovirus. So how does it work? Why do we get the symptoms, or why do babies get the symptoms? So it starts with, once you have the respiratory virus enter the lungs, you get inflammation of those epithelial cells lining the bronchioles, and that results in excess mucus production as well as cellular death. And this results in obstruction of the bronchioles because you've got so many secretions there, which results in wheeze and difficulty in breathing. So just going back to our question, RSV is the most common one because, and just to kind of go a little into parainfluenza, that's more to do with croup, and Streptococcus pneumoniae in that age particular tends to cause pneumonia and meningitis. So risk factors wise, we've got underlying respiratory disease. So that can be something like cystic fibrosis, congenital heart disease, particularly PDAs or the patent ductus arteriosus is more associated with serious disease. Seasonal, so winter, I think winter's the main season for bronchiolitis. You don't tend to see it as much during summer. Immunodeficiencies, so yeah, any immunodeficient children are more susceptible to getting viral infections. And then prematurity. So prematurity associated with respiratory disease. So something like bronchopulmonary dysplasia is associated with more severe disease. So clinical features, symptoms wise, so what we see or what the child will present with is coryza. So just those flu-y symptoms, very like bunged up, blocked nose or runny nose. Cough and wheeze, mild fever, difficulty in breathing, and reduced feeding. So what you would see on the child when you're going to examine them is an increased work of breathing, and that can be demonstrated by tachypnea, so just really fast respiratory rate, decreased oxygen saturations. You might see grunting or nasal flaring, and that's when you start getting a bit very concerned, to be honest. You might also see some like head bobbing too. subcostal and intercostal recession. So that's what parents would probably describe it as kind of sucking in their ribs or like their stomach. And then a tracheal tug, which is kind of just there. So wheeze and crackles on wheeze and or crackles you probably hear on auscultation. Pyrexia, as we said, so usually it's mild, so it's probably not going to go above 40, it'll probably stay under 40. Tachycardia as well, probably more associated with the temperatures. And then dehydration signs, so due to the reduced feeding, you might see reduced to wet nappies and kind of dry mucous membranes as well. So always important when you're taking a history or taking a pediatric history is to ask about how many wet nappies they've had and to know how much they normally feed and how much they're now feeding. So you're able to kind of work out how much it's reduced by. So moving on to our next question. So this is a 5-month-old brought into ED. So mum reports that he's been feverish for the last 24 hours and sucking in his ribs when he breathes. And in the last few days, he's had a bit of a runny nose too. So his mum says that he's been having around 80% of his normal feeds. And on examination, you see that there's intercostal recessions, which settle after nasal suctioning. So observation-wise, we've got them all here. And then moving on to our question. So which of the following is most appropriate? So would you admit for oxygen, admit for feeding support, discharge with antibiotics, discharge with salbutamol, or discharge home with nothing and just a bit of safety netting? So if you want to type your answers into the Q&A box, and I can see them, by the way, so they are coming through. And I'll wait 10 seconds. Okay, we're getting a bit of a mix here. I'll wait a few more seconds. I'll just go back as well, actually. Oh. Okay, the most appropriate is discharge home. I did kind of go back and forth there. And I'll talk you through each of them. So admit for oxygen. So actually NICE recommends that we'd only admit them if it's a child under 6 weeks and their oxygen sats are below 90%. But in children 6 weeks and over, we would admit them only if their sats are below 92%. So the threshold is slightly different here. So under 6 weeks, you're aiming for sats of above 92 and then above 90 for 6 weeks and over. So feeding support wise, baby here is absolutely fine because having 80% of the feeds. Discharge with antibiotics, we wouldn't give antibiotics because as we saw, it's all mainly viral. Discharging with salbutamol inhaler doesn't really work, so it's not really recommended by any guidelines. And then discharge home, this is what we're going to do, and we're going to go through the NICE criteria for admission when we prefer as well. So let's do that now. So say you're at a GP surgery seeing a child, in terms of whether you need to refer them on to either a hospital or like onto pediatrics, you'll consider referral if you find that the child has if the rest rate is over 60, if there's difficulty with breastfeeding or inadequate oral intake, and we tend to go 50 to 75% of the usual volume. So we're expecting that when they're unwell and they've got a blocked nose, that their feeding is going to go down. But the main thing is to see how much it's gone down by. So clinically, if they're dehydrated, so things like sunken eyes, cool peripheries, slow capillary refill time, reduced skin elasticity. So that's when we're kind of getting a bit concerned to do with dehydration. And then oxygen saturation. So at a GP practice, less than 92%, you'd probably refer them on. You wouldn't kind of want to take that risk. And then I'll come on to the bits that I was talking about, because our question had a patient that came to ED, so it's slightly different when they're in a hospital environment. But if at a GP practice, they were seeing saturations below 92%, you'd probably refer them onwards. And then immediate referral, if any one of these, so if you've had apneas, so these are just pauses in the breathing where parents will tend to just report it, where they just say that they just didn't breathe for a few seconds and then they kind of came back again. Sometimes it might be associated with a bluish tinge as well. And if you were to see it, or if it's reported by parents. So if you clinically find that this patient looks seriously unwell, then you'd refer them onwards. And then just checking there's no questions anywhere. And then, yes, and then severe respiratory distress. So if you're seeing the child who's got grunting, those chest recessions, breath rates over 70, then that's kind of classed as severe respiratory distress. And then central cyanosis. And then indications for admission. So say you're in A&E now, so they've referred on from GP or patient has come straight into A&E. We're going to admit if any of the following. So if there's apnea, or there's this persistent oxygen saturation when breathing air of, and this is kind of when we're going to go into a bit of depth. So children aged 6 weeks and over, if it's under 90%, you'd be admitting them. So children 6 weeks and over, you're aiming for SATs above 90%. So it's a slightly lower threshold for older babies. And then babies under 6 weeks or children of any age with underlying health conditions, the target SATs are a little bit higher, it's 92%. So if it's under 92% for a younger baby or a more complex child, then you're going to admit them. So I think there's just a question that someone asked about how in the previous question, the SATs were 91%, but that was because it was a 3-month-old baby. Let me just check that it was a 3-month. I think it was a 3-month-old. Yes, a 5-month-old. So because it's a 5-month-old with SATs of 91%, and this is in ED, you'd kind of be all right to discharge them home because our aim is slightly lower in older kids. Fine. Because as we saw, it's 90%. And then going on, admitting again, so if there's inadequate oral intake, so 50 to 75% of the usual volume tends to vary trust to trust as to if there's a certain cutoff, but I guess it's kind of taking into account the whole clinical picture. And then persisting severe respiratory distress. So sometimes you tend to monitor them for a little while and say this continues, then you're probably going to refer them from ED to pediatrics for an admission. And then history. So this is our next question. So this is a 4-month-old child with coryza for the past few days, now developed an increased work of breathing. So currently taking around 80% of normal feeds. On examination, you hear that there's widespread crackles and a wheeze, and you see that he's got intercostal recessions as well as that tracheal tug. And then again, observations, so breath rate 63, and the oxygen here is 92%, and just remembering that this is a 4-month-old. And he's got a bit of a temperature as well. So which of the following factors is an indication for admission in this child after what we've just kind of had a little read through? So again, you can have like 10 seconds, answer in the group chat, and then we move on. Sorry, I just realized I've got respiratory distress twice, so just ignore that. I think one was meant to say respiratory rate. And then I'll just go back for if you wanted to have a look. And this kind of assumes we're admitting. So it's just which one of these is what we'd take into account when admitting. Cool. Yep, correct. It's respiratory distress. And as we said, as we just quickly just go through them again, so respiratory distress, so when there's persisting respiratory distress, that's when we're going to admit. So age doesn't really matter. It's all about how they are clinically. Respiratory rate here, it was 63, and if it was over 70, then that would be a reason for admission. Oral intake, so again, we're aiming for 50 to 75%. And then oxygen levels, here we're okay, because I think it was, what was it again? 92% in a 4-month-old, which is fine. So moving on to our investigation. So main thing to remember is that bronchiolitis is a clinical diagnosis. You don't need to be rushing to do any investigations. And then, yes, and so, sorry, I did see a long question, but I will come back to that in a second. Yeah, so capillary blood gas is one thing that you can do, and that basically involves a little heel prick blood test for a child. This essentially is the same as, very similar to a VBG, but a bit better, if anything, because it's kind of between, I guess, an artery and the veins. So we're looking at pH, we're looking at PCO2, we're looking at lactate. So if there's a child who's got quite severe respiratory distress, you might expect to see, or you probably will see, a high carbon dioxide, a low pH, and then that's kind of will guide our management, and I'll kind of talk about that a little bit more in a bit. Next thing we can think about doing is a chest x-ray. So this x-ray, we'd only really do x-rays if we suspect there might be like a superimposed bacterial infection, or say on examination you find that there's something more than just crackles and wheeze. You might find there's reduced air entry, because sometimes bronchiolitis can result in atelectasis as well. And then the nasopharyngeal aspirate. So this is just using those secretions, and you can send it for PCR to get confirmation of which virus might be growing, and then throat swabs as well, again, just to see which particular virus might be growing. So most of the time you'll tend to see RSV, but as I said, you can get other viruses too causing it. And then moving on to our, sorry, I think there might have been an error in one of the slides in terms of what was a criteria, but this is definitely the correct one. The younger they are, the aim of the SATs is going to be a little bit higher. The older they are, we can tolerate if it's slightly lower than what's expected. Does that kind of make sense? So if there was a bit of a mistake in the previous slide. Cool. And now next question. So now I've got an 8-month-old. So coming to ED, coryzal, feverish, and has been particularly restless with difficulty in breathing. So on auscultation, you hear coarse creps bilaterally, as well as these visible subcostal and intercostal recessions. So which of the following is not used in the management of this child's condition? And then you've got 10 seconds. Feel free to write, because I am getting your questions and your answers. So just what would you not do in this child? Okay, so we've got a few NG. Cool. So it's actually hypertonic saline. So NG fluids is something we would do. I'll move on to the management after this slide. But yes, so the answer here, what you wouldn't do and what's not recommended by NICE is hypertonic saline. So nasal suctioning, as I said, it's all about the secretions. There's a lot of snot in these babies. They're either always kind of got runny nose, or they've got very bunged up nose. You can constantly hear it when they're breathing. So suctioning helps. Hypersonic saline is not recommended by NICE. NG feeds, fluids tends to help, because as I said, because of their reduced oral intake, our alternative is either NG feeds or IV fluids. And then oxygen. So if they have low SATs, then you'd give oxygen. And then of course, antipyretics if they're having any temperatures. And then I'll move on to the management soon, but we'll do one more question as well. So an 8-month-old boy now, so coming in with a 2-day history of a snuffly nose and difficulty in breathing. Dad reports that he's approximately 1/3 of his normal feed now. so which is quite low, with no wet nappies for the past 12 hours. And on examination, you note subcostal recessions and a tracheal tug, and you also hear wheeze and crackles all over. SATs we've got of 89%. Again, this is an 8-month-old, but 89% of SATs. Rest rate of 55, temperature's normal, heart rate's all right as well. So what would be the best first step? So would you do IV fluids, chest x-ray, salbutamol nebs, oxygen, or antibiotics? And then just going back again to history. So yeah, I'll just give 10 more seconds to do it. Oh, I'll just wait for a few more answers. I think we have 2 answers for one, but if you were able to choose the best first step. Cool. So answer is oxygen. So remember, always A to E approach. Yes, there are quite a few that you might want to do here, but oxygen will come first because A, airway's patent, he's crying, he's probably like, there's no concerns according to the question. So B wise, oxygen sats were 89%, and yes, he's a older baby, but still it's under 90%. So we would start on oxygen. And as I said, IV fluids is a potential, but in this particular situation, he is hemodynamically stable. I think with his blood pressure, it's okay for a baby that age. The observations are quite different when it comes to babies. So even a heart rate of 140 isn't too bad for an 8-month-old or so. They tend to be a little bit higher, on the higher side. So chest x-ray, as we said, wouldn't really do that. Salbutamol nebs, not recommended, and antibiotics, unless you hear something that's localizing on examination, you wouldn't really start on antibiotics. So management, so it's all about supportive care. There's no particular thing that we can give them to make them better. As I said, it's all kind of driven by viral illness, so not really much we can do. It just affects them a lot worse. So oxygen supplementation. So again, just to reiterate, so if they're 6 weeks and above, you want to aim SATs over 90%. So I know that says less on, but it's over 90%, or aim SATs over 92 if they're less than 6 weeks old. So, oh, sorry, I think it meant oxygen supplementation, give oxygen if it's under 90% for children aged 6 weeks and over. So there's 3 different ways in how we can do it. So, or actually 4. There's straightforward one, the nasal prongs of oxygen, or the nasal cannula that you'll see. The next step on from that is humidified oxygen. So that can be via head box, where it's quite literally a kind of like a plastic box. I haven't seen it being used, but it is something that can be used. But it just helps to provide that humidified oxygen so it doesn't kind of go off into the air. And then nasal cannula. So another way of doing it through the nasal cannula is humidified high flow oxygen. So that's essentially it. I couldn't find an image for a baby, so I know that's not a baby. But it's kind of connected to this big machine, which humidifies the oxygen, heats it, and it delivers it through the nasal prongs here. With this particular machine, it's kind of a step up from just nasal prongs oxygen, because it's giving flow as well. So it's kind of through high flow, it helps to keep the alveoli open and prevents it from collapsing, which is, as we saw on like the chest x-ray, can cause atelectasis, it can cause collapse. So it just helps to keep the alveoli open to result in efficient kind of oxygen exchange and carbon dioxide to leave the body. So say you've got a baby, severe respiratory distress, you do a blood gas, you see there's high CO2, this will very likely help in a lot of situations. if it's not helping, if despite this, the baby's still breathing really hard, or you do a blood gas again and you see that the CO2 is higher or still very high and it's not making a difference, then the next step is either CPAP or ventilation, which is a bit more, ventilation obviously very invasive, and CPAP still quite invasive. It's kind of doing, it kind of sets the pressures and things itself. So a big step up from there. And babies don't, this is CPAP and it's not comfortable for babies. They don't like this because it's this big like head gear on them, which isn't comfortable for anyone, to be honest. Fine, but yes, again, I think main thing to reiterate with this is when we're giving the oxygen. So you'd only give the oxygen when the SpO2 is under 90% for those age 6 weeks and over, and then if it's under 92% for less than 6 weeks, so you just have that higher threshold. And then supportive care, another thing is, as we said, suctioning. So it's all about this blocked nose. So suctioning can sometimes just improve their work of breathing, and sometimes even nasal saline drops. So it's different to the hypertonic saline that I'd mentioned. So nasal saline is literally just put in the nose. It's 0.9% and it just helps to dissolve all the mucus. And then another thing is, so oral feeds. So now we're looking at feeding. So we looked at breathing, we're looking at feeding now. Oral feeds. So if they're able to suck and not distressed, fine, let them go ahead, let them continue. But if they're not tolerating oral feeds, or they're less than 50%, or they're just got a very high rest rate and they're under respiratory distress, then your next step would be NG feeds rather than IV fluids, because babies still get hungry. And I think unlike adults who, yes, when they're having IV fluids, you kind of just tolerate it, babies will get really grumpy and they'll start getting distressed and they'll start crying, which just makes the whole thing worse. So NG feeds is preferable. So with this, it's kind of, the same way it's inserting. I think it's a lot easier for babies than it is for adults. And we tend to just give their normal feed. So if they're having kind of like formula milk, then that's what they'll get through the NG. And it's basically because the respiratory distress that they're having makes it hard for them to suck and drink the milk at the same time if they've got a blocked nose. And that's why they can't tolerate as well, or they kind of stop midway, or they don't drink as much. And even then they kind of don't feel like drinking as well because they're just unwell too. Our step up to IV fluids would be if they're not even tolerating NG feeds. So even with NG feeds, you're having, it's filling your stomach up. And when they're having respiratory distress as well as a full stomach, it will just come straight out. And so IV fluids would be the next step up if they're not tolerating NG feeds, or if they kind of had severe respiratory distress to begin with. And even with NG feeds, we tend to go either continuous or bolus. So bolus is more replicating how they normally drink milk. So it would be kind of, say, every 3 hours, they'd have like 2 ounces of milk. Whereas if they kind of are having respiratory distress and you're not yet ready to take them to IV fluids because you think they can manage, we tend to go continuous NG feeds. So it's a smaller volume, kind of every minute. So then it's still keeping them not hungry. But yeah, we're still also meeting their daily amount too. And then what's not recommended, so antibiotics we talked about, bronchodilators is not recommended because at that age they don't have the receptors in the lungs to even respond to bronchodilators, so it's not really shown to make a difference. And in fact, it can have adverse effects as well, so we stay well away. Steroids, no, because it doesn't really work in this. It's not like an allergy related thing. And then hypertonic saline helps in children, say if they've got thick secretions like in cystic fibrosis, but they need to have physiotherapy to then bring it up, because it's kind of it accompanies either a strong cough reflex or physiotherapy. But if you don't have those, then these babies aren't exactly going to be able to cough it up. They don't really know to do that, and they won't kind of voluntarily do that as well, so it won't make a difference. Last question, and then we'll kind of skip the other one and then go. Okay, so to be honest, because I know we're short for time, so I'm just going to skip this question and go for our prophylaxis, which is palivizumab. So this is a monoclonal antibody against RSV, and you can give it as an injection, and there's few criteria, so not every child would receive this. So chronic lung disease is a big one, and chronic lung disease is basically mainly defined by if they're requiring oxygen from at least 28 days from birth. So children under 9 months and born preterm and have CLD, then we'd probably give them, we would give them the prophylactic, the vaccine. And then respiratory diseases. So again, with this one, not necessarily preterm, but if they are requiring oxygen, then you'd probably give them that, because they're going to have the infection a lot more severely if you weren't to give it. Congenital heart disease. So here we tend to do it more children under 6 months. And if it's acyanotic, if they're born preterm as well as that, or they kind of they're a bit hemodynamically unstable with it to an extent, then we'd give them the vaccine then as well. So say if there's any like inpatients too. And then children with congenital heart disease as well as significant comorbidities, that's also an indication. And then SCID, which is severe combined immunodeficiency syndrome. So children under 2 years, so it's a slightly high threshold in terms of the years, even though they might not get it with this particular illness, you can probably get bronchiolitis later on after a year as well. So I think that's it, that's finished. If you have any further questions on it, feel free. Sorry, I think we went a bit over time, but if you have any questions, feel free to email me about it. I did get a few emails last time and I'm more than happy to answer. There's a QR code, so please do fill it in and let me know if you'd like anything else going forward, if there's any particular topics that you want to hear about. I think I'm going to be doing scarlet fever next, which especially last year, I think we went through a bit of a scarlet fever season where there was a lot on the ward, so it's kind of definitely came back up again. So do let me know if there's any particular topics you want to know about, what I can do to improve, or what you liked about it. But yeah, I'll just leave this up for a little while so that you can just fill that in at any point. But cool. Or ask any questions in the group, in the chat as well, if you want me to answer them now. Yeah, I've just left that there so that if anyone else wanted to then feedback for me if you've not yet done so. That's it for today. Thank you. Oh, someone just asked me about other pediatric sessions that have previously taken place and how many sessions. So I've only done one, which I did on kind of chronic asthma in children, and that was 2 weeks ago. And I think that is available to be watched on the Bite Medicine platform, but I'm not too sure which other ones have taken place. But I'll be doing a few more as well upcoming. Cool. Thank you guys.